responder transition course offered by Iowa Western. We're really glad that you're here. We really hope that you enjoy this method of learning and that you find the online course to be, first of all, educational, second of all, easy and convenient. We hope you learned something in this. It's our hope that you always leave courses that we offer being a little better at what you do, and glad that you came. So my name is Cherry Fearing. I'm the Director of Education at Iowa Western. I truly love that job there, and I would really be anxious to hear your honest feedback when you get done with this course so that we can take steps to make it as good as it can be. Okay? A couple things we're going to do as we transition through this course is look at the process of this transition, why we have to take it, and what's that going to involve for you. So this first section is really just to get you oriented into the whole process of transition so that you understand why you have to even go through all this. Okay. Please jot down my contact information. If you have any questions at the end of this course, I would really like to visit with you about those questions and get you some answers. There's a lot of questions out there about these new levels. There's also a lot of information going around that isn't necessarily true. So if you have questions, get in touch with me. My office phone number is listed there. More importantly, my email is listed there. And that's probably the fastest and best way to get in touch with me, because I do monitor my emails almost continuously, and I can get back to you very, very quickly. I am frequently either with somebody in my office, on the phone, or at meetings outside of my office during the day. So sometimes getting a hold of me on my office phone is a little tricky. I will call you back, but the email probably is the easiest way. Okay, so let's look at this. How does this affect you as a first responder? Lots of people that I've dealt with in this transition process, and I'll be real honest with you, most of them are a little disgruntled because they have to go through this step. They don't understand why. It just seems like something else that they're requiring. And for you guys as first responders, I fully understand that most of you do this on a volunteer basis. Now, I want to be the very first to tell you thank you for that. I have lived a great number of years in a very small town in Iowa, and I value, I'm a volunteer myself, and I value tremendously the service that you provide to the community and to the people that live around you. I don't think you guys get enough thanks for what you do, and it's really nice when somebody steps up and says, wow, I didn't realize what all you guys did. It makes you feel good. So first of all, understand that this is not something to just make you jump through some more hoops, but that it is going to make it better in the long run for all of us. Okay, so some of the things that we're looking at, I'm going to kind of go through my spiel here so that you can kind of understand why. We have to look at it from the big picture, not just from me as a first responder, but the overall picture of EMS. If you look at EMS as a whole, we're pretty new. EMS really didn't get started until the mid to late 70s. Now, back when we transported patients to the hospital, that's been going on since Napoleon was in the battlefield. A lot of the times what we did was we transported them back in the olden days in a hearse. And the funeral director would go out, he'd get these people, he'd put them in the back of the hearse simply because that was a vehicle that would hold a patient that was laying down. He'd put them in the back of the hearse and he'd drive to the hospital. They got no patient care, they just got a ride. And when they got to the hospital, they opened up the back of the hearse to see if the patient had survived the trip or not. That isn't what we do today. Okay, today we provide prudent and essential medical care to those those people before they get to the hospital. And that started in the 70s when we started that. So we're a pretty new career. Consequently, we're not seen as a profession. We're seen as a blue-collar worker. Now, on the big picture, I'm a paramedic. Okay? So I can work alongside, and I have, right alongside an RN in an emergency room or in any other hospital setting. My scope of practice, the things that I can do, are exactly the same things a nurse can do. And in a couple different areas, there's things that I can do as a paramedic that a nurse cannot do. And so you would think we'd be paid the same because we do the same job. But the fact of the matter is, I work for about half or a little less than half of what they would pay a nurse to do that same job. And that simply stems from we are not seen as a profession. Nursing is. So our goal, ultimately, is to have EMS providers seen as professionals. Number one, we are professionals. We deserve that recognition. Number two, if we're going to do it for pay, we should be paid at the same rate of somebody else that provides the same care. So as a volunteer, it's going to provide more funding for your department. It's going to provide more funding for your retirement. It's going to provide more funding for your benefits that you have associated with that. Now, I realize some of you in rural Iowa have very few, if any, benefits associated with that. But should that change, you would like to be able to benefit from your education that you've gotten. The other thing is we want our public to understand. Now, currently, in the state of Iowa, we have a whole slew, I think 17 different levels of providers in the state of Iowa. And I'll just kind of go through this little spiel, and I'll use EMTs. Well, no, I'll use you all. We've got first responders, okay? We've got first responders at the 1979 level. There originally was a first responder prior to that. I don't think we have any of those left. But then we have this 1979 first responder level. And then we have created a first responder G level. And I'll be real honest with you, I don't know why that was created. And then we created the first responder 1996 level, which is different than the 1976 or the G level. But we still have all those providers out there. Now in the EMT area, we started out with EMT-A, which stands for A is for ambulance, because those are the first level of providers that can actually give treatment and transport. And then the automatic defibrillators came into popularity, and we started using those on our ambulances. So we said, you know what, some of our EMTs need to be trained on these defibrillators. So some of them were, and those EMTs are now called EMT-Ds for defibrillator. Then we created a whole new level called EMT-B for basic, so EMT basics, and some of the EMT-As and EMT-Ds transitioned up to the EMT basic, but not all of them, so there's still some old ones laying out there. And EMT basics have an entirely different scope of practice than the other two. Then we had EMT intermediates that we introduced. The first ones were introduced in 1985, so we have the I-85 intermediates. And I don't think that was the first ones, but that's the curriculum that we use. And then we said, you know what, let's create a level where we get more advanced care to people without all of the long education of a paramedic. And so we created what in Iowa we call the I-99. We lovingly call that one the Iowa Paramedic is what we nicknamed it. Well, now we have the Iowa Paramedic, but we still have the paramedic level, so we had to upgrade the paramedic level. So they had to take more education, and some of them became paramedic specialists, and some didn't. And what a quagmire. So we have all this stuff going on. We don't even understand it. So how in the heck is the public going to understand it? So the reason for this transition is to get 4 levels of certification in Iowa and in all the other states. And they will all be the same. Because honestly, a first responder in Iowa is not the same thing as a first responder in Nebraska or Colorado or Connecticut or Texas. And it doesn't mean the same thing, and they have entirely different scopes of practice. So we're all adopting the same level with the same minimum education standards and the same minimum scope of practice. And that's going to make it nice so that just as if I would tell you I'm an RN, that's the same in no matter where I go. If I'm in Connecticut, an RN is an RN. If I'm in Arkansas, well, maybe not Arkansas, but no, I'm kidding. If I'm in Arkansas, I know what an RN is. If I go to Washington State, an RN means the same thing. We're going to have that happen in EMS. But the first step to do that is to get all of us at the same level so we can at least make an attempt at that. It's also going to help our public understand what we do. Right now, I've been called an ambulance driver. I can't tell you how many times because the public truly does not understand what a paramedic is or does. They don't understand what an EMT is. They don't understand what first responders do. So for them to understand, we need to get it to a level where we understand and it's the same so that we can then educate the public. Now we're going to be teaching these levels according to the National Education Standards. This is different because when you went through your training, those were taught according to the Department of Transportation standards. So that's been a little change. Not really a lot in the standards. It's just housed in a little different area and will be called something different. And then we will be adhering to the national scope of practice. There'll be some adoptions made specifically for Iowa providers, but the minimum standard in the scope of practice will be this national scope of practice. Okay? So it's really going to benefit us. It's going to benefit our departments. It's going to benefit the public. And ultimately, I think it's a win-win situation. Once you see how easy this is, you're going to say, okay, yeah, I can go for this. So let's talk about that. Okay? At the end of this session, or this course, you will be able to say, yes, I have completed all of the transition requirements required by the state of Iowa to transition to the emergency medical responder level. Okay? Now the 4 levels that we're going to have are going to be emergency medical responder. That's going to take the place of first responder. So all of those first responder levels are going to transition up to this level. Okay? Then we will have an emergency medical technician, or an EMT level. All of those providers that are associated with the EMTA, EMTB, EMTD, all of those will transition to that EMT level. Okay? Or they won't have a certification. Same with first responder. If you don't transition, you lose your certification. The next level is a new level that's called advanced EMT. And so the I-85s and some of the I-99s will transition to that advanced EMT level. It's a really nice level. It provides some medications. They can start IVs, but it doesn't require a ton of education because we don't do anything with cardiac monitors. They don't have to read EKGs. They don't put down advanced airways down a patient's lungs. So it's a very nice level. And then the top level will be the paramedic level. So it'll be those 4 levels in all of the states. Okay? So let's look at when we're going to do this. Because you're going to finish this course, you will have met the education standards that Iowa has set forth. And then when you get your certification, or you're up for recertification, you can click the box that says, yes, I've met those requirements, and here they are. So you're going to see this is going to be very easy for you. Right on here, get my page to transition over. Okay, so if we go to the Iowa Department or the Iowa Bureau of EMS website, you can see the URL up here. Up at the top is a transition link. Okay. Another little cool handy dandy thing on this web page is right down here where it says provider search here on the left. If you click on that, you can search by name for any provider in the state of Iowa, and it will tell you when they expire, what level of certification they have, and if they're active or not. So, but let's click on the transition level because that's what we're looking at today. Okay. When we get on this page, you'll see down at the bottom is your scope of practice. So let's talk about that to see how that's going to affect you as a first responder. Okay. And when you click on that page, down at the bottom is always going to be the most updated scope of practice for the state of Iowa. So we'll click on that. Now this is going to be a long document. But partway through that document, in the first part of it, you're going to see this graph. And now there's two of them. There's a basic level scope of practice, and there's an advanced level. I want to make sure that we look at the basic level. And then you can see over here there's some levels of certification across the top. First Responder 79, First Responder G, First Responder 96, and then this is the Emergency Medical Responder. These blue ones, over here's the EMT. These blue ones are the new levels that will be in place. So at the end of 2014, we will not have any of these other levels. They will all be emergency medical responders, and they won't hold a certification. So we're going to look at that and see what the changes are from where you were over here to where you are now. You can see the First Responder 79s couldn't give oxygen. Once you transition, you will be able to. Okay. You're going to see that they initially could not give an oral airway. They will be able to now. So there's lots of changes. I encourage you to look at this document. We're going to talk about a few that mostly affect the First Responder 96. You can see right there, there's three things that have not been included in the new level. So let's look at what those are. Okay, the first one is the nasal airway, or that nasal pharyngeal, the little rubber-ish tube that would go down a nasal passageway of a patient to protect their airway. That has been taken away. To be real honest with you, that's not something we use. Hardly ever, if ever. Most patients that desperately need the airway are unconscious and can take an oral airway. If they're not, for most of the time you can help position them or help maintain their airway manually. You can help open that airway, or you can suction to get that airway clean. So that's really not something that was prudent, not something that was used, but it will not be in your scope of practice any longer. The other two things that are missing, and this may cause your hair to rise up just a little bit, is the multi-lumen airway, which we use mostly the Combitube here in Iowa. Now, Combitube is something that is important. It is an airway that we did use frequently. And I know you're going, what? They can't take away the Combitube. But most departments in the state of Iowa, prior to this transitioning ever taking effect, have voluntarily started using an airway called the King LT. Now, the King LT is an airway. It goes down to the base of the tongue. You inflate a cuff, and you can manage a person's airway in the same way that a Combitube would. The thing about that is because it only goes to the base of the throat. It's not a multilumen, it's not esophageal and tracheal. It's considered an oral airway. It is very cool. If you haven't been trained on it, you need to be. Most departments that have tried it or looked at it said, wow, I like this. They started using it, their providers love it, and they have gone to it and kicked out the Combitube for no other reason than they prefer the King LT. Now there's a few nice things about the King LT. One of them, it's about a third the price of a Combitube. So if you're paying for your own equipment on your department, that's huge, because a Combitube is running a little over $100. These guys are running about $34. The other nice thing about them is they're easier to use, they're smaller to store, and they come in a variety of sizes. So you can put this in a 2-foot tall patient all the way up to a 7-foot tall patient. Whereas the Combitube, you were limited. Your patient had to be 5 foot tall and they couldn't be over 7 feet tall. So there are lots of advantages to that. And I think once you take a look at that, if you haven't already, you'll see that that King LT is a very, very nice replacement and does fit into your scope of practice as a first responder. The next one is right down here. Humidified oxygen has been taken out. I'm not going to spend a ton of time talking about this because I don't believe any of us anywhere give humidified oxygen at the first responder level. It's not something that you even have the equipment to do, nor do you have the time to take to give humidified oxygen. It's not something that's indicated in that emergent first on scene oxygen delivery. Generally, we give them oxygen via non-rebreather, and it really doesn't matter if it's humidified or not. The purpose of humidified oxygen is to prevent the nasal passages from drying out. You aren't going to have these patients long enough to even worry about that. So, because it just seemed irrational that it was even in there, it was pulled out. So, probably no change at all from what you've been doing. The next thing right down here is pulse oximetry. Now, you may have heard through the grapevine that pulse oximetry was no longer going to be allowed for first responders. Well, in the first run at this, it had been taken out of the national scope of practice. Now, listen to me. The reason was a lot of first responders were treating the pulse oximeter and not their patient. And so our patients were getting adequate care. Our providers were saying, oh my, look, that pulse oximetry says they're at 98%. They don't need the oxygen, they're fine. Okay. Well, if that patient had been exposed to carbon monoxide, it probably would read 89 to 100%. Unfortunately, the treatment for carbon monoxide poisoning, as we'll talk about a little later, is 100% oxygen. Lots of it for a very long time. So, and on the flip side, you may have a patient like, oh my, their oxygen levels are in the 50s. We better give them some oxygen. And so they do all this stuff and get all kinds of oxygen, when in fact that patient may have had nail polish on and was not allowing an accurate reading. Or maybe the patient was cold, their fingers were cold, and you weren't getting an accurate reading. So there is some concern there that at a first responder level, you need to make sure that you are treating your patient and not your monitors. Now, at the state of Iowa, we looked at this and said, we really believe that our guys are smart enough to do this correctly. So there's a little plus sign there. If you look down at the bottom, right here under the IV fluid thing, there's your plus sign, and it says additional training and medical director approval is required for this skill. So if your medical director is willing to say, yes, I am going to make sure they're adequately trained, and I am going to make sure that the use of the pulse oximetry is not being abused or misused, then that can be added into your scope of practice. So that falls directly on your medical director's shoulders. And if you'd like to visit with him about that, I encourage you to do so. The next thing is right down here, and that's the EpiPen, the auto-injector self or peer rescue EpiPen. That has been added into your scope of practice. Now, you have all been trained to use an EpiPen, and you've been trained to use it on a person who's experiencing anaphylactic reaction or that severe allergic reaction which causes the airway to swell. You've also been trained that it has to be prescribed to the patient that you're giving it to. And you know to look and make sure it's not expired, it's the right patient, all of that. You also know how to take the cap off, grasp the EpiPen. Now understanding the end with the cap is not the end with the needle. So you pull the cap off of one end, which activates the needle in the other end. Please keep this in mind. I can't tell you how many EMT students I have seen, thankfully with the trainer EpiPen, that had that EpiPen been real, they'd have injected it in their own thumb. Because it kind of makes sense that the needle would be under the cap, but it isn't. So pull the cap off, grasp around the barrel of the EpiPen, and you're going to inject that using the needle in the other end about midway up the thigh on the outside edge. You're going to push that in nice and firmly so that that needle injects into the skin. You're going to hold it there for about 15-20 seconds and take it out, rub that area, and make sure that you're very careful with that exposed sharp needle. Now, you've been trained to do that with the patient's own EpiPen. The exact same process plays into the EpiPen for self or peer rescue, except that it is not prescribed to anyone specifically. It's an EpiPen that your service will carry with them in their equipment, and that can be used on yourself or someone else that is experiencing an allergic reaction that's causing their airway to swell. You're going to see those signs and symptoms by seeing that they're short of breath, that they're anxious, they'll probably have an increased respiratory rate. You'll probably hear some sounds, maybe stridor, that upper high-pitched crowing sound. You may hear some air trying to squeeze past that narrowing airway. You will probably see some swelling, either in the lips or the tongue. If you look in the patient's mouth, that little hanging down thing in the back might be nice and short and stubby, and that is not a good sign. So if you see those things, specifically if you know your patient's been exposed to something, the EpiPen is going to be something that you would want to contact your medical director about to use. Now, you do have to contact medical direction to use that. But once you've gotten permission, you can use that pen who has not been prescribed to anyone on that person, whether it's a patient, someone in your department, or yourself, for treatment of that severe allergic reaction. So that's been added in, and that is in addition to your patient-assisted meds that you know how to give. Okay? That's kind of cool. The other thing, if you look over on the right-hand side here, is tourniquets. And tourniquets have been removed from your scope of practice. Probably not going to change anything because your first line of defense in controlling bleeding is direct pressure. And direct pressure doesn't happen just bing, bang, boom. You need to apply pressure for 10 to 15 minutes before you even move on to consider the tourniquet. Now, I can tell you, I've been working in this field full-time for quite a number of years. I have never seen a tourniquet used. I have never had the need to use a tourniquet, and I've taken care of some very badly hurt people. Direct pressure, even on arterial bleeding, has always taken care of that bleeding in my experience. Now, I know there's going to be times when it doesn't, but a whole lot of the time, that's going to take care of it. Even in the case of amputations, because in an amputation injury, a traumatic amputation, the body senses that there's blood loss there, and it automatically puts in mechanisms to take care of that. So the vessels that are leading up to that injury actually constrict up and shut down. So in the amputations I've seen, there really has not been a large amount of bleeding and nothing that needed a tourniquet applied. So the thought process is here that you should be applying direct pressure. Hopefully within that 15-minute time period that you're applying direct pressure, another level of care has arrived that could apply a tourniquet should one be needed. So they really want you to try that direct pressure first because it works in almost every situation. Okay, that's that one. And that's it. Very little changes. Okay, as far as how that's going to affect your patient care, almost not at all, except in the case where you can add a skill or two in there. Okay, there's very reasonable rationale for those changes. Hopefully, how I've explained it is going to make some sense to you, so that you can understand why those changes have been in place and agree that you can live with those. Okay, going back to that page, the transition tab, if you go over here, you look, there's on the left-hand side, a link that says first responder. That's going to address specific requirements for first responders. So let's look at those. And you're going to find not many. Okay. We want to click on this EMR transition form to get the specifics. So once we click on that form, this is going to come up. And I've broken it down into the parts that we need to look at here, but it's actually just one document. So what they say that you need is you need training to be able to recognize and manage carbon monoxide poisoning. You need training to recognize and manage nerve agent poisoning. You need to utilize the auto-injector for self or peer rescue. We've just talked about that one. Recognize and manage a patient with signs and symptoms of a stroke. Recognize and manage shock that's associated with vaginal bleeding. And recognize and manage a nosebleed. Sounds pretty important, doesn't it? Okay. Now you're going to look at that and go, I've had a lot of this already. And you probably have. What we've done is we've taken the training that was required. And you may have been trained above the requirements. But we took the training that we specifically required in the state of Iowa for first responders. And then we looked at the training that's required by the educational standards for the new level. And we identified these 6 areas in the medical category that we had not legally required previously. So we're just going to cover those now so that we can say, yes, you have been trained on every area at this new level according to the education standards. If you've already had them, it'll be a great refresher. They count for hours towards your recertification, and you're golden. So no harm, no foul. In the trauma, there's only 2, so we need to recognize and manage a pregnant patient that's been involved in a traumatic injury, and recognize and manage multi-system trauma. And then the last 2 things are look at the age-related assessment changes in our elderly patients, and take a look at the pediatric assessment triangle. I think you're going to enjoy that. That is a tremendous tool, and my bet is you have not had that in the past. That's it. So what it says here is that first responders must complete the transition by their renewal date prior to October 1st, 2014. So that means you're going to transition this September 30th in 2013 or next September 30th in 2014. So you do have to transition in one of those periods. And at your renewal, whether you renew online or whether you renew with the paper form that you get mailed, there'll be a place for you to check, yes, I've completed my transition requirements. If you complete this course successfully, get your certificate, you'll be able to click that box. Then you just renew as normal with that box checked, and the new card that comes in the mail will say emergency medical or emergency medical responder rather than first responder. It is that simple. Okay? Alrighty. That's all there is to it. There is a quick quiz over this information. You need to take that quiz at this point, and you've got 3 attempts. You need to get at least an 84%. It'll be on information that we talked about in this lecture. And so once you get that 84%, then the next lecture will open up. You can view that. There'll be a short quiz after that. Then you move on to section 2, the same thing, and you're done. So it's going to be very simple. We estimate about 3 hours for you to complete the whole program, and we hope you enjoy it. We will be talking to you very soon.